The objectives for Crike are to review the indications of the surgical and needle Crike. We'll look at the anatomical landmarks, and this is really one of the most important things. Obviously, we need to make sure that we're familiar with our landmarks prior to determining that a needle or surgical Crike needs to be done. In particular, the surgical Crike. Review the planning, preparation, and performing the cricothyrotomy, paying particular attention to the PPP and the planning, preparation, and performing. So here's that individual. Maybe you get called to a 32-year-old male with a self-inflicted gunshot wound to the face. These happen. I'm not sure if you guys have individually responded to these, but this is certainly not something that is too far-fetched. This can be a destructive lesion, obviously, which is caused here. This is a large caliber, involves the mouth, the jaw, and the high neck. And there's going to be quite a bit of significant amount of blood from this type of wound. So the question, if you're looking at this, is what are your concerns, right? And your concern, if you go back and you look at this individual, really your airway, breathing and circulation should always be the concern, and it is certainly the concern here. But one thing that I will tell you is you guys need to get away from the habit of becoming distracted by what it looks like and getting back to work. So if we have a situation like this, there's actually a video. I've talked about this a couple times, and I know Josh Cox actually ended up finding it. For those that know Josh out at Independence, who's now retired, but he ended up finding that video and sending it to me. And it was a situation where they had flown a patient in that had suffered a self-inflicted gunshot wound. They had flown him into Cali Shock Trauma in Baltimore, Maryland, and they were saying that they were unable to get the patient intubated. And simply the anesthesiologist or the attending surgeon was able to get the patient intubated because it was a direct entrance into the trachea. So a lot of times we see things like this. We're not used to seeing them all the time. It's going to be a very distracting type injury, and I can appreciate that. But anatomically, if you can still put an endotracheal tube in, or you can get this patient's airway, that's going to be better for this patient. We're not going to get a good seal with a BVM. So think about those types of things as you're doing it. So your biggest concern here is obviously going to be your airway, breathing, and circulation. So from your airway assessment, what questions should we ask ourselves? So first and foremost is, are they moving air? And that's obviously going to be the biggest thing. If they're moving air, then maybe we don't really need to do anything at this point other than maybe some bleeding control. Are they aspirating? That's another really good question. If they are, then we need to think about how we're going to either A, position the patient like we had talked about with a lateral recumbent position, or we can think about either a decanto or a Yonker type suction device so that we can hopefully keep them from aspirating whatever the contents are. Is there an airway obstruction? If so, can we remove the obstruction? Can we do that by the patient either forcefully coughing, or can we do that with McGill forceps, something along those lines? And then what is the neurological status of the patient? Are they mentating appropriately? So I would challenge you that if you had the picture that you had just seen there where the gentleman had self-inflicted a large caliber gunshot to the face, if they're moving air and they're not aspirating and they're mentating appropriately, we probably don't really have to do a lot for that individual, right? We can simply transport them to an appropriate facility, make sure that they're prepared for us when we get there. And then, yes, ultimately, they are going to intubate that patient. They're going to paralyze and sedate them. But that's going to be more from a comfort side of things for the patient than it is for true airway control. So in the field, we have a 7 to 10 or 15-minute transport. I'm not suggesting that you don't intubate them. Clearly, if they need it, they're not moving air, they are aspirating, those types of things, then certainly get your airway and make sure that it's secure. But if the patient is moving air appropriately, they're mentating appropriately, they're not aspirating, then it may be a situation where we monitor this patient and then transport them to a facility that can assist us with getting them intubated. What if they're unresponsive, they have shallow respirations, or if they have any type of bubbling blood or secretions coming from the mouth? Well, now we're in a situation where we know they're not going to be able to protect their own airway. So what we need to do, the next step, is to get them intubated, right? So we're going to intubate this individual in hopes that we can get them intubated effectively, whether or not we're using any type of medications to assist with that, or we're just simply intubating them like we have for many years. Hopefully you can get a tube through the glottis and you can secure that in place. But if you're not able to do that, what I want you to think about here is the next step, right? And we're talking about cricothyrotomy. So what we need to think about is if we are unable to intubate, and I want to be very clear when I say this, if you are unable to intubate and you are unable to ventilate, then you are in a situation where we are thinking about a cric procedure. If we cannot intubate the patient, that's fine, as long as we can make their chest move with a BVM. If you can get an I-gel in the patient, an NP or an OP airway, if we're able to cause ventilation, and remember, ventilation is the mechanical process of the chest moving, if we can do that with a BVM effectively, there is absolutely no reason to move on to a cric procedure. The only time a cric is indicated is two things: inability to intubate and inability to ventilate. And if you can say both of those with a straight face to your medical director, then it would be appropriate to move on to a cric procedure. So if the intubation fails, then we're thinking cric. It goes back to the 3 Ps. So we need to plan, we need to prepare, and then we need to perform. So we need to plan the proper side, the best lighting possible. We need to prepare our equipment, our suction, and our securing device. And then we need to perform. And when we do this, we should be moving quickly and deliberately, but not in a rushed procedure. We don't want to rush this, but we do want to make sure that once we're ready to get down to business and do the cric, that we're actually doing it quickly and effectively. So plan, obtain the best possible position. So if we're going to cric this patient, and obviously a needle cric is going to be an easier procedure to do than a surgical cric, but we need to make sure that we're in the best possible position. So if you are right-handed, think about where you would want to stand for your patient. You're probably going to want to be on the patient's right side so that you can make your incision, or you can place your needle through. So get in the best position possible, whatever is comfortable for you. Obtain the best lighting possible. And unfortunately, in our situation, this may be a flashlight held by a sheriff's deputy or a police officer, or maybe it's in the back of the ambulance, but it's probably not going to be in a very ideal situation. You want to put your hand dominance, your left or right, on the patient's side, okay? So as I said, I'm right-handed. I would want to be on the patient's right side so that I can make sure that I'm in that best possible position. As far as anatomical landmarks here, I covered these and I told you I would talk about them again. Remember, this is your thyroid cartilage or your Adam's apple. Remember, CT towards the head. So the easiest thing to find is your thyroid cartilage. If we can find the thyroid cartilage, you should be able to walk your fingers down. You're going to feel this opening or this potential space here. That is your cricothyroid cartilage. And then the next rigid ring down is the cricoid cartilage. And that is where we would end up doing cric pressure if we're doing direct laryngoscopy or visualization, trying to get our patient intubated orally. The site for doing a needle or surgical cric is going to be in this cricothyroid membrane, and they both work the same as far as what our anatomical landmarks are. If you're going to do a needle cric using a quick trach or a per trach device, and we'll look at those here in just a second, you're going to insert those here into the cricothyroid membrane. If you're going to do a surgical airway, again, we're coming back to this cricothyroid membrane, and I'll kind of walk your steps through how you would do the surgical cric. So we'll talk about that here in just a few minutes. All right, so then we're going to prepare the scalpel, the cric kit, or the 14 gauge angiocath. If you have the ability to do a surgical cric, it's going to be better for your patient. The 14 gauge angiocath is basically buying a couple of minutes at most. It's not going to be the situation where this is going to be a long-term benefit to the patient. We need to think about an Airway 6.0 ET tube if you're doing a surgical cric. So you're going to end up making your incision, and then you're going to take a 6.0 ET tube and slide that directly into the trachea. And then you can just simply attach your BVM and ventilate through the 6.0 ET tube if you have done a surgical cric. We need to make sure that we have suction available, and we need to make sure that we have a securing device. And we'll talk a little bit about what the different parts of this device are here in a few minutes. And then we need to perform, right? So we need to take a breath, and we need to make sure that the patient is able to breathe. And then we need to do this quickly and deliberately. We need to be able to perform the procedure. So one of the things I've told you, if you're right-handed, you need to be on the patient's right side. If you're left-handed, be on the patient's left side. And what we're going to end up doing here is something called the laryngeal handshake. So we're going to end up finding that hyoid bone. Remember, the hyoid is that U-shaped bone that attaches the tongue. You're going to end up walking your fingers down until you can find the thyroid cartilage. And as I told you, that is the Adam's apple, which should be fairly easy to identify. Once you have found the thyroid cartilage, you're going to continue working your fingers down. You'll feel the potential space, and then you'll feel the next rigid ring, and that is your cricoid cartilage. And then as you can see here, they've taken their index finger and they have put it directly over the thyroid cartilage. Once you have located that site, I would recommend that you mark it or you keep your finger there, because if you start manipulating the external anatomy here, you're going to end up losing where the cricothyroid membrane is at. So this is called the laryngeal handshake. And as you can tell, this patient, or this provider, I'm sorry, is on the patient's right side using their right hand. All right. Perform the grip for the surgical cric. You're going to grip with a non-dominant hand, and then you're going to make a vertical incision. And this is very, very important. So remember, vertical is up and down. Horizontal, if you can think of horizon, horizontal incisions would be sideways, and we do not want to do that at this point, okay? So what we are going to do is we're going to end up finding the thyroid cartilage. You're going to end up finding your cricoid ring, and that potential space that I've talked about, or your cricothyroid membrane, that is our target area. So we grip the external anatomy. You're going to take your scalpel and you're going to make a vertical incision through the cricothyroid membrane. We want to get through the membrane and that tough tissue until we can see what we are doing. The reason that we always want to go vertically here is that you have a lot of different vessels, your internal and external carotids, the jugular veins. There's a bunch of different vessels that are running up near here on the lateral aspect of the trachea. If you end up going too far on a horizontal incision, you're much more likely to damage or to lacerate one of those vessels, and that is what we are trying to prevent. So if we can stay directly over top of the cricothyroid membrane and do a vertical incision, we don't have to worry about getting into some of those other vessels. So we're going to make a vertical incision through the skin. And then once we have made the vertical incision through the skin and the tissue, and we can actually see what we are doing, and we can see the vasculature or the lack thereof, hopefully, then you would make a horizontal incision through the actual membrane itself. So vertical first, then horizontal. It's going to end up causing a little bit of bleeding. That is going to be a normal finding. If they start hemorrhaging, you've probably gotten into one of the vessels, and now you have a bigger problem. So again, doing this on cadaver labs and those types of things, if you're able to do it. When I trained, we actually did it on dog labs. I think they have stopped doing that at this point, just because of some of the rights, animal rights, and those types of things. But it was an invaluable learning experience to be able to do that. So remember, vertical and then horizontal. All right. So once you are through and the cricothyrotomy has been completed, then you're going to end up taking a 6-0 ET tube, and you're going to end up placing the ET tube directly through the trachea in this situation, or directly through your cric. If you have absent breath sounds on the right, then maybe you have migrated into the left, or maybe they have a tension of thoraces on the right. So basically, it's just to get you kind of thinking of what your differential diagnoses may be and what you're going to have to do to overcome that. If you have unilateral rise and fall of the chest on the right side only, then your tube is probably migrated into the right main stem bronchus, and simply you could either A, go with it, or B, pull it back out a little bit. What I would caution you in is pulling it back so much that you end up losing your cric or your tube. The other thing that I will tell you, and this was pretty eye-opening in dog lab and on human cadavers, is you think that once you've made that vertical and horizontal incision, that you're going to be able to find that opening again, and that is not the case. Once you have made an opening, you need to put something in it, either your finger or a pair of McGill forceps or something along those lines needs to go in that opening, and it needs to remain there until you get your 6-0 ET tube through, because as soon as you let go from that laryngeal handshake, and manipulating the external anatomy, the tissue underneath is going to move, and you're gonna end up losing where that opening is at. I promise you. So once you've made the opening, keep something in it until it is fully secured with your endotracheal tube. The main stem intubation through the cric. So if you kind of think back, we talked the trachea is 8 to 10 centimeters in length. So here's your trachea. Obviously, the endotracheal tube is going to be a little bit longer. So probably what we'll end up doing here is we insert through the cricothyroid membrane. That endotracheal tube has come down and it's just migrated into the right. And that goes back to your initial education as to why that happens. All right, with the needle cric, not nearly as effective, but unfortunately, that may be the only thing that you're able to do. It does provide some oxygenation, but it does not really provide adequate ventilation. So this kind of goes back to the apox thing that we talked about. If you can get them adequately oxygenated, it's probably better than nothing. But we know they're not necessarily going to move their chest and have proper ventilation. The other downside to this is increased CO2 levels will occur. So yeah, we can probably, and nobody's really carrying jet insufflation devices anymore. When I started, they had a jet device on the ambulance because it was required by K-beams at the time. So you would do a needle cric, and then you could hook it up to a jet, and you could provide ventilation through that jet, and it was 50 PSI. So we could definitely get the air in. The problem is you're unable to get the air out. And that is why they end up having this increase in CO2 levels. They become hypercarbic. And then that ends up leading to respiratory acidosis in about 30 minutes. And then you have bigger problems on your hands anyway. So a slight movement in the head can kink or dislodge the catheter. Remember, we're just using, in a lot of situations, or historically in a lot of situations, we were just using an IV catheter. In today's world with quick trach, per trach, obviously those are a little bit better and a little bit more stout, so it should not kink or dislodge as readily. The advantage of a needle cric, ease of access. Hopefully your landmarks are easily recognized. Remember going back to that CT towards the head and finding your cricothyroid membrane. The ease of insertion, it's literally sticking a needle through. Minimal equipment is required. You do not have to make an incision, and it requires only minimal training that everybody has received in initial, at least paramedic education. The indications for your needle cric, as we've talked about, is not only can you not intubate, but you also cannot ventilate. So there's no other alternative airway method in order for you to get the patient's chest to rise and fall. And when that happens, now we're in a situation where we need to think about doing a cric. The contraindications, insufficient training, and again, not throwing stones, but if you're not in a situation where you're used to doing training, then you probably haven't practiced a cric. In my estimation, probably since you went through paramedic school, at whatever point that was. Now, if you're an instructor and you're teaching in a paramedic program, or you do continuing education internally, then maybe that's not the case. But generally speaking, people go through, they get to training, they have the knowledge, and then they never do it again. Lack of proper equipment, ability to secure the airway using another technique, and then complications, as we've talked about, you're not able to get that CO2 out, so they become hypercarbic. Damage to surrounding tissues. One of the most important is obviously going to be the vasculature that is underneath, and then catheter displacement. So here's some of the equipment. Obviously, top center of the screen, our BVM. Hook that up to 15 liters. Make sure that this is extended so that you have your reservoir and you're providing 100% oxygenation. We're going to need a BVM to ultimately attach to either the quick trach or to our endotracheal tube. So if we're doing the quick trach or per trach, the different parts here, we obviously have a 10 cc syringe. You can do something called a Seldinger technique. And what the Seldinger technique is is if you can imagine you're advancing this catheter through the skin and ultimately into the trachea while pulling back on the plunger. As you're going through the skin and the tissue, you're going to have resistance. But as soon as you get into that potential space or the trachea, that plunger is going to come way back. And that tells you that you are in the proper positioning. That is known as a Seldinger technique, and it's pretty effective if you've ever had the ability to do that. So we have an over the needle catheter. You have a red stopper. And what this is, if you've never really paid attention to that, that red stopper is to ensure the depth of the puncture. So we don't want to go too much further than that. Hopefully, if you can kind of bury this, depending on how big your patient is, if it's an adult patient and these are sized appropriately, here's a size 2, 22 to 77 pounds, and then a size 4, 77 pounds and greater. And this red stopper will be at the appropriate depth based on how big your patient is. Your 10cc syringe that I've already talked about, your Velcro securing device, and then right here is your extension tubing so that you can hook the trach directly to your BVM and you can ventilate your patient. If we're using a cric procedure, if you have a 14 gauge, a 12 gauge, anything like that, the bigger the better. In this situation, we do not need something that is going to be very long. We only need, again, the length as to what this is for our catheter, and it may be a little bit more difficult to find that, and it's not manufactured that way. But once this has gone through the cricothyroid membrane, we're going to end up pulling this back portion of the catheter off. You end up taking an adapter from a 3.0 endotracheal tube. This adapter goes into your needle, and then that adapter will go directly onto your BVM. And again, for those of you that have gone through paramedic training, you've been taught that and probably have practiced that hopefully at some point in time. For those of you that have not gone through paramedic training, if you have questions, get with one of your medics and have them explain to you how that portion works. Or certainly reach out to us and we'll be happy to answer questions regarding that.